as we're thinking through this. For CKD-related anemia, what do you see as potentially being the most impactful advantage associated with the use of HIF stabilizers for the treatment of CKD-related anemia? How do you, Dr. Palmer, think through that in terms of that question?
Well, yeah. So one of the first advantages is the ease of administration. So remember, these are oral drugs, and they're just taken once a day, and that is incredibly an advantage over the way we currently, as compared to the erythropoietin stimulating agents. The other really advantage that I see is the evidence that not only do these drugs lead to increase erythropoietin production, first of all, in a very physiologic way, but also it enhances concomitantly iron absorption. And it enhances iron absorption and utilization even in the setting of inflammation. So, the evidence that these drugs really are going to be a more effective way to treat anemia is pretty convincing, I think. So, again, ease of administration, the idea that you're going to get iron absorption that's facilitated. These are some of the big advantages I see as compared to our current treatment strategies.
Great. Thank you, Dr. Palmer. Let me we have some pre-test, post-tests also for this, so maybe we could pull them up and have folks answer it. But how do you observe increases in plasma EPO levels compared between ESA and HIF-PHI treatment? Both therapies induce comparable increases in plasma EPO levels. ESA induced more moderate increases in plasma EPO levels, or HIF-PHI induce more moderate increases in plasma EPO levels. Can we have folks try to answer that? All right. Well, what do you think about this, Dr. Palmer? What do you think that? It seems like folks are picking both, but there might be a different answer here.
Yeah. So people have actually, and I alluded to this earlier. Just think about this: when you give an erythropoietin stimulating drug, immediately after it's administered, the EPO that you're giving goes very high levels, and then it falls down. Whereas, and that's because you're giving the product directly, parenterally, whether it be IV or sub-Q. On the other hand, the prolyl hydroxylase domain inhibitors, what they're doing is causing your own body to increase its production. So the rise of the erythropoietin levels is quite slow and continuous. And you don't have this big bolus, so to speak. And again, I think that's going to make these drugs more effective in the sense that there'll be less side effects. So, for example, one of the things we have to be cautious of when we give somebody erythropoietin stimulating agents is what is their current level of blood pressure? Because if it's way out of range, we hold the dose because it can make your blood pressure worse, probably related to these very high levels that are transiently given. So again, I think it's the having your own body produce it to facilitate that process is really an advantage of this new class of drug. Yeah.
Great, thank you. Let's maybe move on to a quick next pre-test, and then we'll open up a question. A patient with HER2 positive advanced GI cancer treated with trastuzumab presents to the ED with dyspnea, dry cough, mild chest pains. The patient explains symptoms are causing interference with activities such as shopping and preparing meals. What grade of adverse events does this mostly reflect? Grade 2, 3, or 4? Music. Well, we'll get to have you talk about this, Dr. Kitchens, because it seems like half the folks are picking grade 3, but there might be a better answer to that question, along with the fact that, besides working through that, if you have any comments about, how hospitalist-based physicians, can respond and treat the patients with acute distress with evaluation of the events such as TRAE, and and any comments about that from a larger picture in the hospital setting. Sure.
Well, I think, there's a few more data points that you're going to need here. I mean, yes, it appears she's having, clinically relevant dyspnea on exertion. She's actually having shortness of breath that's interfering with just kind of regular activities, which are not that exertional. And it ended up being severe enough to bring her to the hospital. We're going to need to know, how hypoxic she is. And of course, we're going to want to get imaging. It's not going to be inappropriate, to have a low index of suspicion to treat these folks with steroids if they have the appropriate clinical history and what drug they were taking. In this case, she was getting, again, the question, I'm sure she was getting trastuzumab deruxtecan, or was it just trastuzumab on here?
I only have I only have the information that's on there.
That's a different thing, because if it's just trastuzumab, then we're not worried so much about the pulmonary toxicity. That's more for depressed ejection fraction and TTE. But I'm going to assume it was the trastuzumab deruxtecan antibody drug conjugate, because that's what we've been talking about the whole time. So that's going to be, a situation where if you have the imaging findings, if you have the clinical findings with hypoxia, you're going to want to go ahead and start steroids. You're going to want to talk to the patient's oncologist. And, as we were talking about earlier, if these folks have a grade 2 to 4 pulmonary toxicity from that drug, the oncologist is going to want to stop giving the drug in the future. But the most relevant thing for the hospitalist taking care of the patient that's sitting in front of them is going to be the question of giving steroids or not. And honestly, it's not going to be wrong to do that. I can't imagine it being wrong to do that. So that's what I would want to do: give steroids, and of course see what their oxygen levels are and see what their imaging is, and pick up the phone and talk to the oncologist.
Great, thank you. Let's move on to the next question here. So prophylactic therapy with lactulose and rifaximin is recommended by AASLD and the European Association for the Study of Liver Diseases following which of the following: second episode of overt HE within 6 months of the first, second episode of overt HE 6 to 12 months after the first, and second episode of overt HE regardless of time frame. Now, I know you haven't received the lecture yet to the audience, but give it your best shot. We'll let Dr. Rahimi give his thoughts on it after you do, and I'll ask Dr. Rahimi a question here shortly. So what do you think, Dr. Rahimi, about the answer to this question? And then I'll ask you a question.
Okay, great. Well, it's a very nice bell curve here, 25%, 44, and 31%. Obviously, this is a tough question. You guys haven't had the lecture, but just to give some background, lactulose is given for patients with hepatic encephalopathy, which is confusion of the brain due to chronic liver disease or cirrhosis or portal hypertension, and we'll go over that. After a patient has failed lactulose therapy, what happens is if they get readmitted to the hospital, and that's called, quote unquote, a failure of lactulose therapy, the FDA guidelines and the AASLD and EASL guidelines do recommend rifaximin therapy. And we'll talk about the readmission rate and what rifaximin does to decrease that readmission rate. So that's the current label for the drug. To reinitiate or at least start rifaximin after a failed lactulose therapy. But we'll go over the lecture.
Now, is it, and just one thing, is it in addition to lactulose again when they're readmitted, or is it in replacement of lactulose?
Great question. It is in addition. So the New England Journal study by Bass et al., which I'll show on my slides later, shows that 90% of the patients in that study had concurrent use of lactose with addition of rifaximin. Now, a lot of patients decide this is in replacement to lactose, but to get the full benefit, at least what we've seen in studies and for patients in readmissions, you take lactose and then you add on rifaximin after they've failed the lactose therapy.
Great. And then, Dr. Rahimi, tell us a little bit from your perspective about the role of hospital-based clinicians in initiating prophylactic therapy for HE, that for patients that are hospitalized and now stable following treatment of lactulose. We talked a little bit about that, but then the management of driving, this, at some point, is it still always lactulose and then failure leads to rifaximin, or does rifaximin become first line at some point?
Yeah, that's actually a very interesting question. Currently, and the way the evidence-based medicine is, it's lactose with rifaximin therapy. Now, there are studies ongoing, which I'm part of, doing research to find out. So in the future might be a little different. And there's newer therapies that are sort of coming out with different mechanism of actions that we'll talk about. But at the current time, it's lactose and then rifaximin. So for the hospital medicine group, a lot of patients that come in, if they're already on rifaximin, obviously they continue it. If this is their second episode, they usually start it. Obviously, GI or hepatology is in general consulted, but some hospitals don't have GI or hepatology. And then the thought would be to prescribe rifaximin after, again, they've failed lactulose therapy, and refer them to a GI or a hepatologist for outpatient to help manage. Because at that point, sometimes insurance, believe it or not, will not approve it for different reasons. Although they did change the ICD-10 code recently to incur hepatic encephalopathy. So hopefully it'll become better and easier to prescribe to decrease readmissions.
The other for all three of you, before we end the session here, so thank you, everybody. How hospitalists on one end are specialists in the inpatient setting, right? And but they're also generalists in the fact that they see a lot of different pathology, right? So there's this kind of generalist specialist component that they have in their background and the work that they do. There's a ton of new medications, new approaches to therapy. We're hearing all three of them here on this call. Some of them are starting in the outpatient setting. There's a movement of care to the ambulatory setting. Whether it is in the oncology space or the nephrology space or the liver space. Yet these patients end up coming into the hospital. They're not actually managing the long-term approach to, so they're not seeing the long-term. It's either initiation or continuation or starting before they leave, before the patient leaves. What advice do you have for the hospital medicine specialist to keep up with this stuff, and to, fit this into their practice, if you like? My talk at the beginning centered around collaborative care, collaborative care between inpatient hospital-based clinicians and primary care or ambulatory-based clinicians. But it's getting a little bit tricky with all these new medications, the nuances around them, and yet not in a given year, they may only use these medications or see them a handful of times.
Yeah, I'll take this since the other speakers have given their lectures already. Give them a little rest. So that's exactly right, Dr. Amin. Collaboration is very important, but communication also, right? So that goes hand in hand. As we all get lost in our electronic healthcare, medical records, notes that people, they become longer and longer, copy forward, all those things where they can't tease out, what we're actually trying to accomplish with patient care. I think picking up the phone and calling, the hospice or running into them while we're rounding becomes very important. That collaboration and communication is very, very important because everyone is a expert in their own field. I'll be honest, hospitalist medicine is very challenging. It's getting more difficult. I did it for a while, for 6 months in between my fellowships, and they have to be good at everything, but only know a little piece of the pie. And so consulting your colleague, but actually talking to them, communicating with them, and just asking a direct question, becomes very important. I think we're starting to lose that communication gap. And the hospice that I consider different, or at least separate from the other hospice that are compared, like the top-notch hospice versus the ones that just want to get their work done and not communicate, are the ones that communicate, pick up the phone, call you, run into you in the halls. Hey, can you really tell me what's going on? I can't understand your notes. And then that becomes very important. So never be afraid to call us. That's the most important thing, in my opinion.
So it's back down to even more than having great knowledge. What I'm hearing from you is availability and affability is more important than ability, if you like, right? I mean, I'm using ability with knowledge, if you like, in the 3 A's, but to be a great hospitalist from your perspective is really, communication, and you don't need to know everything. You just need to kind of be willing to help move things along. It is getting challenging, especially as the throughput pressures and you're spending a lot of time on systems stuff.
Yeah.
How do I call the insurance company to get them to move along? And how do I deal with the case managers to get things to move along, right? Which is taking away from the care process. Anybody else have any thoughts on this question?
I just wanted to say I completely agree with Dr. Rahimi on that issue. As far as communication is the most important part. I work at the same hospital he does, and I can think we're probably thinking of some of the same hospitalists that are the top-notch ones that would call us and talk to us, or the ones you can stop and talk to in the hospital. The communication is key. So often we're bogged down in the electronic medical record, and we're relying on the electronic medical record to get our point across. And when it comes down to it, talking to somebody is really going to be tremendously more valuable than anything else. So I completely agree on that.
Great, thank you. Let me flip the question, then we'll end the fireside chat. What can you guys do as specialists to help make the job easier for the hospitalist from a communication standpoint, right? Because there's one side of this that says, hey, communicate with us and, you become a top-notch hospitalist. It's more about that. But isn't there a piece here, and I just wanted to get your thoughts, isn't there a piece here of, hey, I'm coming in to do a consult. I know the pressure that the primary is going to have. Let me actually, write a few lines about, hey, look out for these side effects and do this. Or, I think the patient can go home, but I want to see them in 2 days, or something along those lines. That may actually even save a phone call, but help facilitate communication. We don't see a lot of that happening as hospitalists. We have to spend that extra time to say, hey, what do you want to do? Do you want to see them in 2 days or 7 days when I discharge them? Or, hey, what do I have to look out for in terms of you're telling me to start teclistamab, but what do I have to look out for? But if you told us up front, it would make our lives easier. And again, it's in this whole spirit of collaboration and orchestrating care.
Yeah, that's exactly right. And to your point and Dr. Kitchen's point, we've had our hospitalist group make suggestions, and we have to be better communicators, right? So we actually have to communicate that to them. And through at least our hospital at Baylor, what's happened is they have come up with a plan, like if you were going to discharge a patient the next day, to please be kind enough to put in your note and maybe even bold it, like, okay to send this patient home tomorrow on prednisone, and then spell it out, 60 milligrams times 3 days, whatever, 40 milligrams times 3 days, and I will see them in my clinic within 1 week. And so, and literally that, and when you bold that in the electronic medical record, that like you said, it saves a phone call. You can actually text that or let your hospitalist know. And when you communicate, it makes it such a smooth transition, 1 day or 2 days before, because then that also turns into early discharges. And, hospitals are going to early discharges before noon. If they have to try to, they might have 10 patients to discharge, but if they know ahead of time, then in their sign out, because we've done a better job communicating, then they can actually have better patient care, get other patients into the hospital. So I think the flip side of the coin is we have to also do a better job. And it's a team effort again. It comes down to that.
All right. Wonderful. Any other comments before we break? All right. Dr. Kitchens, Dr. Palmer, thank you very much. Always a pleasure. Thank you for thank you for the wonderful talks, and thank you for collaborating with us on HM Summit.
Thank you.
Great. Let's move on to our last topic here.
Sorry, doctor. Sorry to interrupt. We just need to do the post-test real quick here.
Oh, sorry. All right. We'll go ahead and start. How do observed increases in plasma EPO levels compare between ESA and HIF-PHI? If folks can answer that. All right. Well, any comments, Dr. Palmer? I think we talked about this, correct?
Yeah, I think we talked about it. One's more physiologic, the other not so physiologic.
Great. Thank you. All right. Next question. The question on HER2 advanced GI cancer, trastuzumab presents to the ED with these symptoms that you see. The patient explains symptoms are causing interference with activities such as shopping and preparing meals. What grade of adverse events does this most reflect? 2, 3, or 4? A little bit of improvement, but we talked about this answer also. Dr. Kitchens, any last quick comments? You're still muted.
No comments. I think the big thing is just you need a little more clinical information, but outside of, worsening dyspnea, at rest or findings on imaging and actually documented hypoxia, I think we're going to be falling in a grade 2.
Great, thank you. And then prophylactic therapy with lactulose and rifaximin. Dr. Rahimi went through this, but let's answer this question, everybody. Okay, improvement, Dr. Rahimi. Any last minute comments? I know you're going to talk more about.
Yeah, this is a tough question because I haven't gone over the lecture. So without giving the answer away, to keep our audience engaged and to stay tuned. So can I leave it at that so they can actually come back and actually listen to the lecture, and they'll know a little better after the lecture, hopefully.
Perfect. Okay, well, Dr. Kitchens, Dr. Palmer, thank you so much. Look forward to working with you again in the hopefully near future. Let me go ahead and get us started at with our last topic here. So our last topic is on evidence-based care and therapeutic updates to reduce the risk for rapid progression and recurrence of hepatic encephalopathy. Gives me great pleasure to introduce Dr. Robert Rahimi. He's a transplant hepatologist and GI, the gastroenterologist at Baylor University Medical Center, associate professor in the Department of Medicine at Texas A&M University College of Medicine in Dallas, Texas. Dr. Rahimi is board certified in transplant hepatology, GI, and internal medicine. He holds a Master's of Science in Applied Physiology from the Finch University of Chicago and a medical degree from Chicago Med. While completing his internship and residency in internal medicine at the University of Virginia, he concurrently obtained a Master's of Science in Clinical Research in the Department of Public Health. Dr. Rahimi completed 2 fellowships, the first in GI at the University of Texas Southwestern, followed by a fellowship in transplant hepatology at Baylor. Dr. Rahimi's clinical interests include chronic liver disease, liver cancer, liver failure, metabolic and autoimmune diseases of the liver, viral hepatitis, complications of cirrhosis and liver transplantation. He has authored several research articles on improving the outcomes of patients with advanced liver disease. Dr. Rahimi has also completed numerous peer-reviewed publications and serves as medical journal reviewer for a number of prominent journals. So I am thrilled to have Dr. Rahimi with us. This shows some of his research support and consulting engagements. The learning objectives today will be to describe a plan of care for patients hospitalized with hepatic encephalopathy that is consistent with update evidence-based recommendations, review the efficacy and safety of therapies for treatment of acute episode of overt hepatic encephalopathy and prevention of their recurrence, identify crucial components of a transitional care plan to prevent future hospitalizations among patients with HE. And let's do some pre-polling questions. John is a 45-year-old male who presents to the ER with disorientation, asterixis, and personality change per observation from a relative who brought the patient in. On further examination, the patient was unable to correctly state the month, day, and week, but did know their appropriate location. Which of the following grades is this patient according to the West Haven criteria? Grade 1, 2, 3, or 4? Okay, they're kind of split between grade 2 and 3, so we'll let Dr. Rahimi tell us about that. According to Aishen, how long would you wait to add additional therapy for lactulose, to lactulose for management of overt HE if there's an inadequate response to lactulose? 8 hours, 16 hours, 24 hours, or 48 hours? All right, it's either 8 or 24, so we'll let you respond on that. Which of the following therapies has been shown to improve outcomes and reduce hospitalization when used in combination with lactulose for HE prophylaxis? Lola, PEG 3350 electrolyte solutions, rifaximin, or zinc? Okay, most have chosen rifaximin. Which of the following is among precipitants of HE in patients with cirrhosis that should be reviewed with patients at discharge? Low protein diet, constipation, or joint pain? Split between low protein diet and constipation. All right. with that, I'm going to hand it over. Dr. Rahimi, take it away. Thank you.
Okay, thank you. Well, I want to thank Dr. Amin and as well as Hospital Medicine Summit and Integrity for inviting me back. It's always a pleasure. So we will talk about hepatic encephalopathy, otherwise known as HE. Now, it's really important because this is a reversible neuropsychiatric disorder that patients that have chronic liver disease or cirrhosis can actually improve on. And so 30 to 45% of them have it. And I think it's a little underreported. In 2018, there was an estimation about 200,000 adults in the US that had it. The symptoms range from obviously being slightly neurologically impacted by having confusion of the brain or psychiatric alterations to coma. Now, it's really, really high in recurrence rate. It has been shown that the health-related quality of life is really poor, not only for patients, but also caregivers, and it's worse outcomes in general. So what is hepatic encephalopathy and what is the pathophysiologic mechanism? Well, this illustration here is the role of the gut microbiome in liver disease and HE. So everything we eat or drink that has protein in it has to get digested in your stomach, as well as get broken down to form basically to absorb nutrients, right, in your small intestine, in your GI tract or gut. Now, there are bacteria that do this, and the byproducts actually can be toxic. It turns into ammonia. However, that being said, ammonia is only one part of the equation. A lot of studies have focused on ammonia, but ammonia is not the end all be all, and that will become important. And we will talk about that and show some evidence-based medicine on that. Now, when you have a diseased liver, the ammonia that gets circulated back into the bloodstream and back to the liver with the Krebs cycle, the liver can't break it down. So when it can't break it down, that ammonia becomes toxic. It crosses the blood-brain barrier, and then those astrocytes, which is in the brain, they swell because of osmosis. And because we have skulls and it can't expand, the brain, when it swells, there's the sense of confusion. If it gets really, really high, then you can imagine that the patient can herniate and die. That's very, very rare, though. So the gut microbiome is very important, and there is dysbiosis in that. So ammonia is really, like we talked about, the underlying primal pathophysiological mechanism. However, it's not the end all be all. You can look at the muscle in this illustration, the kidneys, as well as the gut or the intestines, the liver especially, because in liver disease, these patients can't break down that toxin, which is ammonia, and then it crosses into the blood-brain barrier, causes those confusion. Now, when you get shunting, so although patients can have cirrhosis and get this problem with hepatic encephalopathy, patients that have portosystemic shunts, which are naturally occurring, or non-cirrhotic portal hypertension. Portal hypertension means high pressure in the liver system, either with a portal vein thrombosis, which is a clot, or other causes that causes a high pressure. They can act like they have cirrhosis, but really that portal pressure causes this brain swelling and causes hepatic encephalopathy. Now, glutamine becomes an important factor usually in that case, and there are enzymes for glutaminase, glutamine synthetase, that is in the muscle and the kidney and the brain. And this translation between the two factors plays a pathophysiologic role, and there are targets for those areas. Now, what are the characteristics that really show worse outcomes following the diagnosis of HE? Well, when you look at, usually they're older patients, okay? In general, they're end-stage renal disease that actually can lead to high ammonia because you can't secrete out ammonia through not only your liver, your kidneys, okay? And patients that are based on their race relative to white patients, if you look at it based on hospital days and adjusted rates, the minorities, blacks compared to whites, had an increased risk. And the patients that had Hep C as well as hepatitis B on an adjusted risk was significant as well. Now, the characteristics associated with poor outcomes following a diagnosis of HE that look at in gastroenterology consults, so GI consults, those on rifaximin, patients that have worsening portal hypertension or ascites, varices, or TIPS, which is transjugular intrahepatic portosystemic shunt, these all become significant to a level as well as liver cancer, hepatocellular carcinoma with worse outcomes. And the Charlson Comorbidity Index also becomes relatively important when you look at worsening Charlson Comorbidity Index, and these patients do poorly. Now, what has CMS done to change the diagnosis? It's actually, I think, very important. October 1st is when they changed it from the ICD-9 and ICD-10 codes to K76.82. And the reason that becomes important, it classifies hepatic encephalopathy as its own diagnosis. As you recall earlier, I mentioned that I think it's underreported, right? Because the prior code took into account basically just generalized cirrhosis or decompensated cirrhosis. So if someone had hepatic encephalopathy and they coded that, well, it fell into this big bucket category of cirrhosis. So that didn't really help anyone. And not only that, it really didn't help when you want to prescribe rifaximin for patients that have failed lactulose therapy, because a lot of insurances, not that they wanted to basically not approve it, it's just the coding was incorrect. So they thought, oh, you're giving it just for cirrhosis? Well, of course, that didn't make sense to them. But now, hopefully going forward, my estimation is it would help insurance company actually when they get the paper for rifaximin therapy, if it's indicated, they'll say, okay, well, this is the exact code that we need, and this is the indication for dispensing rifaximin. So I think it's going to actually improve over time. So my colleague, Dr. Bajaj, looked at the 3 villages of HE, how you look at HE development, how it's affected, the village is affected, and then what's required to manage it. So the development, if you look at it, we talked about barriers of the dysbiosis, impaired gut and immunity. We'll talk about it a little more, but really there's good bacteria and bad bacteria in our gut, okay? When we have the good bacteria, some of the bad bacteria in cirrhosis is higher, and that breaks down those proteins that we talked about. And the byproduct is ammonia for some of those bad bacteria. Now, lactose and rifaximin, it does change the structure of the gut dysbiosis. It makes sort of the better bacteria more abundant, and that's why HE is reduced. Now, there is genetic components that have been looked at specifically, and that's why some people with cirrhosis portal hypertension, they get admitted more to the hospital rather than the ones that have the same, portal hypertension. It's because there's a genetic component. There's some haplotypes, which are not going to be important for this talk, but we know that those people with those certain haplotypes, they have more hits of HE, and then they get readmitted often. These patients of having, basically a protruding abdomen, very thin extremities, arms and legs, and that alters their skeletal muscle, right? Remember that diagram that I showed, skeletal muscle does actually help with some HE. It actually has shown in some studies that it absorbs its ammonia sink. But if these patients are muscle wasted because cirrhosis is a catabolic state, meaning it breaks down muscle, then there's a problem. That's one prong of the puzzle. Renal dysfunction becomes important because you can't excrete, ammonia, although the majority is coming from the liver, and worsening portal hypertension. Now, how does it affect the village? Okay, think about it. The patients, if they're confused, they might not know they're confused, but their loved ones, they would be very concerned. If your loved one at home had any altermentation or were confused, you would want to take them to the hospital. That affects the caregiver. So they take the patient to the hospital. It might be their first episode or multiple episodes. They can't work, not only for the patient as well as the caregiver. Their well-being, they're more stressed out in general, and that leads to more hospital readmissions. Now, it also leads to patients falling more often and having driving impairments. And we'll touch on the driving simulator that Dr. Bajaj has done and what that means and what the responsibilities of physicians are for driving and if they need to notify any authorities. Now, the village required to manage HE. So the hospital medicine becomes very important, like we talked about on the Fireside chat. Mental health, nutrition, actually, we want actually sort of higher protein diets. But remember, cirrhosis breaks down muscle. If it breaks down muscle, then you cannot absorb sort of the ammonia, and it's a catabolic state. So we actually want high protein. Back in the day, 10 to 20 years ago, they said high protein is no good because that protein causes more ammonogenesis. But the new studies show that actually it's more beneficial because most of these patients do not take a lot of protein. Even people without liver disease, it's hard to eat, 80 grams of protein to 100 grams of protein a day. Now, family and caregivers become very, very important, and educating them becomes really crucial. Following up very closely within 1 to 2 weeks, and we have a system in place at Baylor that gets these patients in very quickly to try to prevent the readmission, and then physical therapy and social work. So HE in the hospital setting. Now, the trend is really going up, and this is old data that went up to 2014, where it looks at the total hospitalization increased by about 25%. You had 38% prolonged hospitalization. The average day of stay in general is about 5 days for hepatic encephalopathy, and the mortality is much higher for these patients because they're at risk for infections. 45% had in-hospital mortality based on this study. Now, what are the factors associated with the higher risk for HE in patients that are hospitalized with cirrhosis? So my colleague, Dr. Tapper at University of Michigan, looked at this, and portal hypertension, which we talked about, high pressure in the liver, which can be from mostly cirrhosis, but are also, portal vein thrombosis clots or non-cirrhotic portal hypertension, which are about 3% of the cases, increases the risk almost 3.5 times compared to the ones that don't have portal hypertension to have hepatic encephalopathy. The cause also is important for alcohol-related versus NAFLD, which is non-alcoholic fatty liver disease. That's becoming a big problem nowadays, and over time, they're estimating that fatty liver disease will become the #1 cause of liver transplant. But the alcohol-related diseases are still a little higher, and the reason is this: alcohol increases the portal hypertension and causes worsening portal hypertension. So you have more pressure. That pressure can translate to brain pressure, I guess you can say, and that will end up causing more hepatic encephalopathy. And what about medicine use? Well, benzodiazepine had a 1.19 increased risk, GABAergics 1.17, opioids, which is now there's an opioid epidemic, and we're trying to control that, as well as PPIs. You might think about, well, how would PPI, proton pump inhibitors, how can that affect HE? There was a couple studies actually before Dr. Tapper wrote on this that looked at proton pump inhibitors, which is usually generally overprescribed. What happens is that causes lower acid, right, in your stomach. You're on a proton pump inhibitor for whatever different cause, reflux or ulcers. But if you stay on it long term, the stomach acid that is supposed to kill the bacteria, the bad ones, let's say, or things that we eat to kind of make things a little more sterile. Now with a proton pump inhibitor, your stomach is more basic, or I guess less acidic. And when that happens, you have other bacteria or the bad bacteria to grow, or at least over dominates the good bacteria that's keeping things in check. And when that happens, guess what? Then that ammonia breakdown and stuff becomes more. So it is actually very interesting that we never thought of that, but it shows that, overprescribing medicines also, you got to be careful about that. Now, what about this 30-day remission associated with poor survival in hospitalized patients with HE? Well, if you look at the survival probability on the y-axis and the days, and in light blue on the top, the readmission is not within 30 days versus the dark blue on the bottom within 30 days. You can see as you go out to longer days, 300 days on this x-axis, patients readmitted less than 30 days of in-vet hospitalization had a significant lower calendar year survival versus those not readmitted within 30 days. So the hazard ratio was 4 times higher. Now, factors contributing to readmission of HE. So this becomes important. Failure to fill prescriptions, lack of follow-up, poor social support, and other diseases, comorbidities, lead to readmission. And we'll talk about this a little more in detail. There's lots of factors involved in each of these buckets. So how do you recognize and diagnose HE? Believe it or not, there are different types. There's type A, B, and C. For this talk in general, we'll be focusing on type C, which is cirrhosis, because that's what we mostly see. That's what hospital medicine mostly sees. But just know there's other kinds. There is acute liver failure. We get a couple per year. That could be from Tylenol overdose or different medicines that cause that, but that also can cause HE. It's a different category because that's acute. Usually these acute liver failure need liver transplant immediately, and there's different causes, but that's beside the point of this talk. Type B, which is portosystemic shunt or bypass, is also common. Some patients with liver disease form these bypasses on their own to decrease the pressure. Growth factors happen where their liver or part of their spleen, they form these splenorenal shunts or bypasses. Or remember that TIPS, the hepatic intrahepatic portosystemic shunt, which we talked about. That's a procedure where our interventional radiology colleagues, they actually go through the neck and place a stent in part of the portal vein through the liver, and that bypasses because of high pressures. If someone has variceal bleeding or recurrent refractory ascites that's not controlled by medicine, that's the indication for that procedure, to do the TIPS or life-threatening bleeding. Now, when you do that, you're creating a bypass, right? That is also increased risk of hepatic encephalopathy. So, and then type C. So the West Haven criteria has been, I guess, the gold standard for a while. And this is something we use to diagnose HE. It's more a clinical diagnosis, okay? So minimal and grade 1 HE, if you think about it, is you get some alteration in psychomotor speed and function. There's no clinical evidence of mental changes when you think about the minimal or covert HE. Really, for paper pencil tests is when you can actually diagnose this. But these patients are usually outpatient. They might be a little slow to speak. They have some sleep-wake cycle disturbances, same with grade 1. And when you ask about this in clinic, this is our job to do that, is, hey, do you have any sleep-wake cycle disturbances, meaning you're taking lots of naps during the day, sleeping late at night? That can be the first cause of HE that can lead to overt HE, which is going to be the next slide, grade 2, 3, and 4. Now, these patients for grade 1, they have some addition, subtraction problems when you give them paper pencil tests. They are oriented to time and space, which becomes important, okay? They actually know what's going on. They might be a little slow. I always think of grade 1 as like the post-call intern, or if you worked like, a 30-hour shift. Back in the day, we would stay awake, and then you're driving home and you're a little tired, but you're a little confused too. Now, grade 2 and 3 are the hardest ones to separate. So let's just jump to grade 4. Grade 4 is coma. You can't wake up these patients, even sternal rubs, they don't wake up. You need to get them out of grade 4 quickly, otherwise they can herniate, right? Grade 2 and 3 is the one that even hepatologists have a difficult time with. So if you look at the description, it's grade 2 is lethargy or apathy, disorientation for time, okay? And then obvious personality changes. They can have asterixis, which is a clinical finding. Asterixis is when you hold out your hand with the palms dorsiflex, the patient will actually have a flapping tremor, okay? Sometimes to make it a little more obvious, because sometimes patients are, they're not that confused yet, you tell them to close their eyes, spread out their fingers, and then you'll see the flapping tremor. That's the clinical diagnosis to really diagnose HE. Now, these patients in general, remember, they're disoriented for time, but not space. Grade 3 is disoriented to space of where they are. So they don't know their country, their state or region, city or place. That's really the difference. Now, again, grade 2, they can be disoriented for time. They don't know the day of the month or week, season, or year. But the one that separates grade 2 and 3 is disorientation to time, which is grade 2. Disorientation to space, not knowing where they are, like city or country or state, is when they're grade 3. Now, covert versus overt HE. We talked about this ESHIN. We were part of the ESHIN guidelines to look at this. Covert are the ones that are really minimal HE or grade 1. You can manage them as an outpatient. Overt are the ones that get admitted to the hospital. These are the ones you see, grade 2, 3, and 4. That's based on the West Haven criteria. So it's a clinical exam, okay? Remarkable markers are this asterixis and disorientation. So anyone with liver disease that has confusion and asterixis, okay, that's the clinical diagnosis. You do not need ammonia levels, okay? That becomes very important. They could have mild hypokinesis, psychomotor slowing, and attention deficits. How do you stage it? Well, the gold standard is West Haven criteria, and the quantitative testing, which we've been part of, is doing in paper pencil tests. Now, precipitating factors over at HE. There's multiple of them. There's dehydration, okay? That can come in a lot of forms. That can come from us as hepatologists or GI doctors, because if these patients come to clinic and we put them on diuretics, there's a couple things. They need to be on the diuretics to get rid of their ascites, okay? That's their portal hypertension. But we can overly dehydrate them if we don't check frequent labs. So it becomes very important to do that. Now, they can get dehydrated from obviously nausea, vomiting, and that's dehydration. They can also get dehydrated, which ties into the second one, acute renal failure. If you give too much diuretics, or let's say it depends on their sodium balance, if they're watching their sodium intake and the diuretics that we prescribe, they can go into acute renal failure, right? That's a precipitant for HE. Lactose or paracentesis. So let me back up. The dehydration and acute liver failure, which is part of the large volume paracentesis, which showed 9%, sort of is combined with all this. If we take off too much fluid, don't replace it with albumin, and they're still on diuretics, you can imagine we're dehydrating them. That can lead to HE. Now, really kind of the number one, even though it shows 42%, but this was based on this study, is infection. I mean, dehydration, acute renal failure, large volume paracentesis, vomiting, all these things all tie into one. But infection, you always have to rule out infection, because those other ones are pretty obvious based on clinical history. But based on clinical history, you can't get an infection history, right? Most of the times they might bump their hand on some table and they have an open wound and they get an infection there, or they have a dog or cat at home and they get an infection, or their guts. They're prone to infections, okay? Their gut, they have a leaky gut, and that bacteria can go into their bloodstream. We all have bacteria, right? We're all made up of more bacteria than normal cells. So that's becoming very important. Constipation is also important, and that kind of ties into the lactose non-adherence. It's kind of semantics. Lactose non-adherence means patients are not taking lactose the way they're supposed to be prescribed, or they just don't want to, because the goal is to achieve 2 to 4 bowel movements a day. Think about it. Like, you might not want to have 2 to 4 bowel movements a day. Someday you're traveling somewhere, it's Thanksgiving, you're going to actually eat a lot of protein that day, but you're at someone's house. They might just take it in the morning, just to have one, but they don't want to have to excuse themselves four times or so. So that's non-adherence, but it's a relative term, right? Constipation, well, they can have a relative constipation, meaning they don't take the lactose, so they're not having bowel movements. So indirectly, they're constipated, but that becomes important. Now, the opioids and benzodiazepine definitely can affect ultramentation. Hypokalemia, the reason that's important because it can cause ammonia is NH3, ammonium is NH4. It has a positive charge on it. When you have hypokalemia, it goes back to the acid base in the kidney, and ammonia then can't get to ammonium. So what happens? You have more ammonia in the system that causes the brain swelling. But if, because of the hypokalemia, if you correct the hypokalemia, then you can actually add the positive charge back onto ammonia to make ammonium, and they can get less confused. Hyponatremia, GI bleeding tips, we talked about that. That becomes very important. But the key here, high protein diet is 0, okay? In the past, remember, we want them to be on high protein diet. That is not a deterrent at all. Okay, diagnostic tests. You guys all are great at this, okay? You get CBCs, comprehensive metabolic panels. The one thing I would say in a patient that comes in with HE, although their white blood cell might not be elevated, because remember, they're immunosuppressed, technically. If they're immunosuppressed, they might not mount a white count response. So the one thing I would ask is to get, blood cultures, UA urine cultures, sometimes a chest x-ray, to pan culture these patients because they're at a high risk for infection. And that's the only thing that truly would change management, because otherwise you wouldn't put them on antibiotics. But if you find an infection, great, you can treat them. Besides obviously putting them on lactose for standard of care. And of course, if they're on rifaximin, which we'll talk about, that's the only thing that would change management. Sometimes we even do put them on antibiotics and wait for the cultures to come back. Paracentesis become crucial. You have to check to make sure they don't have abdominal infection. When they have all this fluid in their belly all the time, that's a nidus for infection. If you think about it, leave any cup of coffee or milk or whatever beverage out open, it's going to form mold. So paracentesis becomes crucial. To do the paracentesis, to check for cells, there's something called spontaneous bacterial peritonitis. Again, that requires therapy, but if you don't do it, then you won't know. and then alcohol level if you're suspicious. So what are the differential diagnoses? We've talked about some of these: alcohol, drugs, neural infections, electrolyte disorders like hypokalemia, hyponatremia, meaning low potassium, low sodium, any epileptic, non-convulsive, or psychiatric disorders, intracranial bleeds, but usually you get that on history. They either have neurologic deficits like facial droop, they can't move their arms or legs, and they have a fall history. Severe medical stress means ICU. If they're in the ICU for a long time, they can have that. And then diabetes, where like DKA becomes important. Other presentations, they can have some dementia, brain lesions, or obstructive sleep apnea, which goes back to the acid-base thing I was talking about, and the positive and negative charges that add on to ammonia. Okay, so how do you treat acute overt HE? There's really a four-pronged approach here. And this is based on our national guidelines, ASLD and EASL guidelines. You want to provide supportive care for the unconscious patient, obviously. You want to find and treat alternative causes. That's the precipitants that we went over. You want to identify the precipitant factors and treat them, and you want to give them empiric therapy. That's why checking for infections becomes important. Patients with liver cirrhosis and altered sensorium, this is the algorithm. So you want to do the ABCs: airway, breathing, circulation. If they have a low Glasgow scale of less than 8, these patients go to the ICU. Sometimes they need to be intubated. You want to make sure their breathing is fine and their circulation with bleeding. You want to exclude other causes that we talked about in detail: electrolyte disorders, hypoglycemia, renal failure, breathing issues, intracranial bleed, benzodiazepine overuse. And this is how you treat them. Generally, you want a direct treatment based on the precipitating factor. Remember, the infection is very important because it's hidden. If you don't do the paracentesis, if you don't do the blood cultures and all that, well, it might be 2 days or so before you figure it out. You're like, oh, they're not getting better. Well, then that's why infection workup is very important. The other stuff, if someone's coming with GI bleed, vomiting blood, that's pretty obvious. You give them blood products if they need to. You might need to intubate them. You definitely call us so we can do upper endoscopy and band varices if we need to. And then if they have constipation, you ask them, how many bowel movements have you had in the last couple of days? Or every day, are you taking your lactulose? If they're not, you want to treat with lactulose. You will know if these patients in general come intoxicated. Sometimes the alcohol level becomes important, and get nutritional support. And then the treatment for the acute setting is obviously lactulose, and then additional therapies if they have no response within 24 hours. So remember, that's important, within 1 day. Okay, so you sometimes, because the patients, they might not admit to you, I've had 2-3 bowel movements, doctor, and that's the typical dose for lactose. But guess what? Most people, including GI and hepatologists, do not ask what the bowel movements are. They say, 2-3 bowel movements, then you should be fine. However, did they ask what the 2-3 bowel movements were? I usually ask, in a cupful, how much would one bowel movement equate to? And sometimes you'll be surprised, those 2-3 bowel movements a day, they've had pebbles. So it doesn't even fill up half a cup. Okay, so that's really a relative 2 to 3 bowel movements. It's not even 1 bowel movement. So they're behind the 8 ball. They're getting relatively constipated, or they're not achieving the 2 to 3 soft bowel movements. So then then lactose might actually help. Lactose, if you give it within a day, 24 hours is the key before you reinitiate or give them rifaximin if indicated, which we'll talk about. Polyethylene glycol 3350 electrolyte solution, otherwise known as Golightly or Miralax, that's off-label, and we'll show that study, and Lola, which now initially was not part of the U.S., but now you can get it, although it's not covered really by insurance. So these are the available therapies. Non-absorbable disaccharides, lactose. We talk about the promotion of ammonia to ammonium, the positive charge, right? Then it shifts the flora from urease to non-urease producing bacteria, which we talked about. Remember, it breaks down ammonia. And then it causes bowel movements. So when you have a cathartic effect, you get rid of the ammonia through the stool. Rifaximin as additive therapy after they failed lactulose, as the current FDA label stands, reduces ammonia by eliminating the ammonia-producing colonic bacteria. Remember, it changes the gut dysbiosis, the good and bad bacteria, and it reduces overt HE. Zinc enhances the urea formation for ammonia to amino acids. Most of the patients are zinc deficient. By the time you check a zinc level, it'll take a week to come back. So usually we don't put these patients on zinc, but if they're not responding, then you want to give them that zinc therapy, or at least as a chronic outpatient. Now, PEG 3350 electrolyte solution off-label has shown as basically getting patients out of HE within that 24-hour period before reinitiating lactulose. It causes obviously a diarrhea, and it produces kind of like what a colonoscopy would do, right? Because this is a colonoscopy prep. Ornithine phenylacetate, these are emergent therapies, but we did the study with the phase 2B. It's an ammonia scavenger. It binds ammonia. It lowers ammonia level, okay, independent of gut action by a different mechanism, which becomes important in patients with cirrhosis. So it actually causes ammonia to be secreted or excreted from the kidneys. But we've only gone up to the phase 2B. Phase 3 will be starting hopefully soon. So this is, again, off-label. It's not ready for prime time. Lactose and reduction of ammonia in overt HE. So the initial dose is 30 mils orally 3 times a day. And then, of course, if they're in HE, I actually recommend give lactose every hour until they've achieved 3 to 4 bowel movements. Then you can slow it down to 3 times a day. Now, if they can't take it orally, what do? Well, there's enemas. The nurses won't like it, but the goal is to get these patients out of confusional states. 300 mils in 700 mils of water of normal saline is enema, and you try to retain it for 30 to 60 minutes every 4 to 6 hours. Obviously, the enemas, they come out with the stool, but that has shown to improve patients with HE. Adverse events, well, they can be aspiration, dehydration, hypernatremia. Too much diarrhea causes dehydration, right? So you have to monitor their sodium. Obviously, lots of bowel movements causes severe perianal skin irritation. And then the same thing, if you get too high of an ammonia and over dehydration, you can actually get worse HE. So this study by Bass et al. On the the Fireside chat where we didn't go over rifaximin, okay? This was the landmark study, New England Journal, where over 90% of patients had lactulose and rifaximin, okay? The survival overall with lactose and rifaximin, if you look at the green, on the top, had better survival compared to just lactulose alone. And how safe is it? Well, in general, the safety with rifaximin, which is in the green compared to placebo in the red, is there was no statistical difference. So although the chart might look like, there is a little more nausea, maybe a little more or peripheral edema or ascites, really there was no statistical difference between the two, meaning the p-value was not significant. And so I wouldn't worry about that. It was basically safe overall. And again, being on lactose over 90% based on this study, and what we recommend need to be on lactose with additive rifaximin therapy. So this off-label study that we did, a small study, looked at, it was called the HELP trial. And we wanted to, as a proof of concept, say, okay, let's say we don't give them lactose, and we just want to prove that having a catharsis effect, having lots of bowel movements within a 24-hour period, can we achieve time to HE resolution? Again, off-label. And polyethylene glycol did a better job for rate of HE reduction. Mean HESA score, which is this big paper pencil test, takes about 20 minutes. And you do based on clinical findings and the paper pencil test findings, subtraction, addition, some division, depending on what level they were, we would grade their HE. And it's been validated across all grades of HE, showed that polyethylene glycol compared to lactose was overall statistically significant within that 24-hour period. This was the phase 2B study that we did with ornithine phenylacetate in hospitalized patients with cirrhosis and increased ammonia levels on acute HE. Remember, this is a different mechanism of action. It's not ready for prime time still. We still need a phase 3 study. And glutamine from ammonia gets broken down, right? And then there's ornithine phenylacetate, which binds ammonia, and it's secreted into the kidneys with phenylacetylglutamine. So it's a different mechanism of action. Now, when you looked at 231 patients, you could see that there actually was no statistical significance. However, the interesting part of it, the intentional treat analysis on the bottom graph with 201 patients, so 30 patients were excluded. And the reason that was important is because when those 30 patients were excluded, those were the ones that actually had normal or very slightly elevated ammonia level, almost basically normal. And you might ask, well, why was that not done in the beginning? Well, the problem with this is when you get the study, these studies are very hard to do. You have to send out the shipment to a central lab for them to collect and run and see what the actual ammonia is. You can use the ammonia level to recruit them in your study in the hospital, but every hospital has different ammonia levels. And believe it or not, ammonia levels, the reason why it's not important to diagnose HE, although most people think it is because there's 7 to 10 different causes of false elevated ammonia levels. I'll give you 2 or 3 examples. The most common is it's not put on ice on 4 degrees centigrade and ran within 15 minutes. So what happens? The tech goes down the hallway A, gets all the patient's blood in the morning, goes down hallway B, hallway C, whatever, maybe on 2 or 3 floors. By the time the ammonia is not on ice or the ice is melted, you get a false elevation, okay? And they run the test an hour or 2 later, well, that's gonna be elevated. That's why we never recommend it as an outpatient. So these patients specifically, when they were removed based on the central lab reading ammonia, they found out, well, their ammonia wasn't elevated. That's why this is an ammonia scavenger. The ammonia scavenger could not scavenge ammonia because they had normal levels. That's why when you took those 30 patients out, you found a p-value of 0.034. So prophylaxis and recurrent overt HE, indications for HE prophylaxis. So the EASL guidelines, lactose is recommended as secondary prophylaxis following a first episode of overt HE and should be titrated to obtain 2 to 3 bowel movements. And this was a strong recommendation. Rifaximin as adjunct to lactulose is recommended as a secondary prophylaxis following greater than or equal to 1 additional episodes of overt HE within a 6 month of the first dose. So this is EASL guidelines within 6 months of the first one, right? So someone fails lactose therapy, they get lactose, they get readmitted to the hospital, so that's a failure if you want, and you call it by the strict definition. You should add on rifaximin therapy, okay? Within 6 months of the first one. Now, the AASLD and the EASL guidelines for 2014, which were the older one, lactose is recommended for prevention of HE after initial episode, and rifaximin is add-on to lactose for prevent recurrent episodes of HE after the second episode. So that was more generalized, and the EASL guidelines is within 6 months. So sort of going back, well, we'll get to the questions later, I guess. Now, lactulose, this is a study by Dr. Sharma and their group, and you can't do this study anymore, but they looked at lactulose, this was done in India, versus placebo, maybe no therapy. Lactulose did show the probability of HE to be much less, statistically significant, 0.001, compared to placebo. So almost 47% of those with placebo got HE. Within a year, about almost 50% got it, versus lactulose, only 20%, drawn out to about a year and a half. The BASS study that we talked about, effects of rifaximin on breakthrough HE, so readmissions. Over a 6 month period, rifaximin resulted in lower rates of both overt HE, meaning rehospitalization, and HE-related hospitalization, which was statistically significant. Remember, these patients also were on lactulose. Rifaximin is in green, and you can see there was a 50% reduction in breakthrough HE episodes, versus HE-related hospitalization, 40%. So additive therapy, 50% less recurrence in HE episodes. So it's very important to add rifaximin if patients have failed lactose therapy. Now, long-term maintenance, if you look at the ones in green, dark green, solid green, you can see that's all rifaximin, all comers, compared to the ones in gray where placebo, or the dashed, green, is historic rifaximin, and there's, 2 dashed, one that's horizontal, one's at diagonal. Overall, HE-related hospitalization, all-cause hospitalizations over a 2-year period were better with rifaximin, right? Without any adverse events. So transition of care for these patients, long acute overt HE. You really want to plan for discharge. You want to talk to the patients for their neurologic status, confirm how they're doing. But it's very important to educate the caregivers, because remember, these patients, when they get confused, what happens? They can't remember. They will not take their lactose when they're confused. The caregivers need to know, and they need to be sort of checking in on their loved ones that, hey, are you having, 2 to 4 bowel movements a day? Make sure it's soft or semi-solid. That becomes important. Education with the role of nutrition, prophylactic therapy if we need to, driving considerations, and a recommendation of vaccines become important. And then the discharge follow-up, this sort of is in our realm that we really need to see these patients, or at least if you're in a practice or doing hospital medicine or general internal medicine, to get these patients seen within 1 or 2 weeks. because two things can happen. Ideally, 1 week post-discharge. They might not be able to fill the medicines that were prescribed, right? If you give them rifaximin, you won't know until they come back to clinic if they got that filled. They might say, doc, I went to the store, they didn't have it, or I haven't picked it up yet, or, the insurance is giving me a hard time to filling the prescription. But remember, they have the new diagnosis code. So you want to adjust those medicines plus the lactose. Remember, re-educate them as an outpatient on the 2 to 3 bowel movements. And that becomes very important. You also want to tell them about precipitants and what to look for, what to avoid, and how it's important for blood work to be checked. Remember that precipitants that we talked about in great detail for acute renal failure, constipation, dehydration, electrolytes, GI bleeding, all these things, infection, lactose, non-adherence, large volume paracentesis, meds, the benzodiazepine, opioids, tips and shunts, as well as portal vein thrombosis. You can see that all these causes in general, compared to which ones were the most frequent: dehydration, kidney injury, lactose non-adherence, infections. And we talked about that, but this is based on a different study. Now, the central role of nutrition in HE management. Remember, the muscle breakdown. Cirrhosis is a catabolic state. It breaks down muscle. When it breaks down muscle, what happens? Then they can't really absorb ammonia. That's one part of the equation. Sarcopenia, which, basically lack of muscle, impaired muscle health, inadequate protein intake. So the target is 35 kilocalories per kilogram per day in the non-obese. And you really want to avoid periods of fasting if you can. So small, frequent meals. So that's 1.2 to 1.5 grams per kilogram per day of protein intake. And you can consider branched chain amino acids. So that's a lot of protein. Even if let's say you say 1 gram and someone's a 80 kilogram individual, 1.2 to 1.5, I mean, we're getting close, 100 grams of protein. That's very hard to do. I mean, challenge yourself to eat 100 grams today or tomorrow and see how hard and challenging it is. But we recommend, protein shakes and all that. So that becomes important. Dr. Bajaj, my colleague, who writes a lot on hepatic encephalopathy, and he's done influence of driving overall with minimal HE. He's done lots of simulations, prior HE, comorbidities, driving experience, medications, fatigue. And he put these people through this simulation, and what he found was there were lots of accidents, near misses, and getting lost. So he puts them through a simulation, and there's a voice that is telling the patient, okay, at the next stop sign, make a right. And then the patient would make a left. So that's a miss, right? It completely, getting lost to the destination. There's maybe a jaywalker coming out and the patient doesn't brake fast enough, or they got into more accidents. So that becomes very difficult for patients and family. Now, the driving assessment, short driving history should be taken in every visit. On-road driving tests, which, that is left up to your Department of Motor Vehicles. Driving simulations, which Bajaj is really good at. Driving history, cognitive testing, but cautions, physicians do not have legal authority to withdraw a patient's driver's license, but they might be obligated to report unsafe drivers to the authorities. And we advise these patients not to drive 3 months after the last overt HE, because remember, they might not fill their medicine, they might have their recurrence rate of HE within the first month, 30 days, even right after that, up to 3 months is really high. And so it's very important to know that we might have to tell them, hey, look, do not drive for 3 months. Let's get this stable under control. There's no evidence to support a driving ban, okay, to these patients with minimal HE without a prior overt HE. And you initiate or optimize HE therapy. You want to decrease sedative medicines. You actually really shouldn't, even if you go to the dentist and they give you a narcotic or benzodiazepine, I think it tells you on the bottle, you do not operate heavy machinery, or they'll tell you, do not make any business decisions today, because sometimes you can make a big mistake, right? Refer to authorities for formal testing to resume driving privileges. Now, what about Dr. Tapper? When he looked at impact of combination lactose, rifaximin, and GI consultation in post-discharge outcomes in patients with HE, if you look at the gastroenterology consult versus just giving rifaximin, in general, rifaximin was in green. I don't know if you can see that clearly, but the green is the lower bars on the left, where following HE discharge, rifaximin effect on mortality was better, okay? And in person with greater than 1 year follow-up without HE. And landmark analysis where we looked at high impact papers versus accounting for competing risks. So he took all this into account, and actually rifaximin did better than consulting your gastroenterologist. If the indication was there where the patient has failed lactose therapy, prescribe rifaximin, so decreased hospital readmission, they have better outcomes. Remember, it's a non-absorbable antibiotic, and it helps the gut microbiome and dysbiosis. What about effect on hospitalization risk? Well, compared to gastroenterology, which is in blue, and rifaximin had an adjusted incident rate ratio that was lower for hospital days after HE diagnosis. 30-day readmissions was lower if you prescribed rifaximin, again, after they failed lactose therapy as an add-on therapy. And hospital days greater than 1 year follow-up without HE was also lower compared to just consulting GI. So that becomes important. Now, what about the case study evaluations? Let's go over the case. Case 1, patient 1, Henry, 52-year-old man, history of cirrhosis, comes to the emergency room for severe abdominal pain for the last 3 to 4 days. And the wife says, you know, he's developed some mental status changes, has some nausea, vomiting for the last day. He denies having a sore throat, chest pain, myalgias, or anosmia. The exam, reveals shortness of breath and a temperature of 99.6. Testing reveals elevated liver tests, LFTs. Patient demonstrates a mild cough, but otherwise normal respiratory exam. His chest x-ray is unremarkable. Which of the following tests would be of little prognostic value in the patient's assessment? Is it ammonia levels? Is it serum electrolytes, blood cultures, or PCR tests for COVID-19? So which will be of little prognostic value? Okay, great. The majority said ammonia levels, and that is actually correct. I can understand we're all tired of COVID and you think like, shortness of breath and all that, and, PCR testing for COVID because we've been through so many strains. So although that's the incorrect answer and little prognostic value, really the answer is ammonia. Remember, hepatic encephalopathy is a diagnosis based on clinical exam, asterisk is ammonia, even though it is one of the pathophysiologic mechanisms. It is not the end-all be-all, and it does not look at prognosis, and it does not diagnose, actually, HE. Okay, let's see the next one. Yeah. What is your next course of action for this patient? Do you want to provide supportive care for the unconscious patient? Do you want to identify and address the precipitating factors for HE? Do you want to initiate empiric HE therapy or evaluate alternative causes of HE symptoms, or all of the above? Okay, majority, 93% got it right, all of the above. Obviously, the other ones are correct too. Identify precipitating factors, empiric therapy, evaluate alternative for HE symptom, but you want to do all of them. So, all right, case 2, Gina. So 68-year-old female comes in with a history of cirrhosis, recurrent overt HE, meaning comes in a lot, right? Presents with acute episode of HE, so overt HE. Patient lives with her daughter and son-in-law who reports that she has been sleeping more than usual over the past 2 days. Patient is stuporous, lethargic. Her responses to questions are delayed. She doesn't appear to know what day it is or where she is. The patient is currently being treated with lactose. When asked about adherence and maintenance therapy, her daughter responds that she is generally reluctant to change any eating-related behaviors and complains constantly about the GI side effects of lactulose. So once the current HE episode is resolved, what changes, if any, to the patient's prophylactic therapy would you recommend? Would you recommend no change? Would you adjust the patient's dose of lactose? Would you prescribe rifaximin as add-on therapy, or would you prescribe PEG as an alternative? Great. 73% of you got it correct. Prescribed rifaximin as add-on therapy. Remember, this patient had recurrent overt HE, kept coming in. The adherence, she didn't maybe like to take it. So how are you? I guess you're not going to do no changes to adjust the patient's dose of lactose. Well, they're not really taking it correctly, or wants to avoid the side effects, right? So, and they have recurrent overt HE. So the FDA label is, the guidelines also say you want to add rifaximin therapy as add-on therapy, right? You still tell them take your lactose. They probably won't take it as much as they want to, but when you add the rifaximin on top of it, then that does a great job and decreases the readmissions by 50%. So prior to leaving the hospital, the patient asked about restriction on driving. How long would you advise the patient to wait before driving again? Is it 6 weeks? Is it 2 months? Is it 3 months or 6 months? So to restrict driving, when would you tell the patient before they need to drive again? The majority of you got it right, 41% at 3 months. It's a tough question. I had one slide on it that talked about restricting the patient for 3 months because the data shows that, within 30 days, they also have a high risk of readmission, but sometimes up to 3 months. So we want to make sure that these patients are stable for those 3 months. Now, to summarize, HE is a major complication of liver disease that represents substantial healthcare burden in the hospital setting and also for caregivers, right? The healthcare providers should be aware that patients with cirrhosis and COVID-19 may present with signs of HE that are high risk factors for poor health outcomes, to include death. And you want to manage the goals that the management really of the goals are to include active treatment of acute episodes, prevention of recurrence, and evaluation for surgical interventions. Several agents have shown to have good efficacy when administered in the acute setting or as secondary prophylaxis. And following an acute episode of HE, prophylaxis, patients' education, and follow-up are essential, really, to prevent the recurrence of hospitalization and improve healthcare outcomes. So the clinical pearls that you should take out from this talk, hopefully I did an okay job on presenting them, are for patients with decompensated liver disease, you want to get a great history, right? On the mental status changes, you want to rule out other neurologic disturbances and evaluate the need for HE therapy. You want to utilize complementary strategies for ammonia-reducing supportive care and nutritional support for these patients with acute overt HE. And you really want to consider secondary prophylaxis with lactose and or rifaximin in patients with previous overt HE episodes that are at higher risk for rehospitalization. And you want to really assess the nutrition for basically all patients with cirrhosis and HE, because remember, it's a catabolic state, and you want to encourage, calories, adequate calories, which include protein, fiber, and micronutrients. And the post-toll polling questions, which Dr. Amin, I think, is going to go through.
Yep. Thank you, Dr. Rahimi. So John, again, is a 45-year-old, comes into the emergency room with disorientation, asterisks, personality changes. Patient was unable to correctly state month, day, and week, but did know the location. Which of the following grades is the patient according to the West Haven criteria of 1, 2, 3, or 4? Music. Thoughts, Dr. Rahimi?
Yeah, good. So they got this, they improved. The answer is grade 2, 46 initial pre-test and then 56 post-test. Remember, this is the hard question. mention that even for hepatologists, it's very difficult to notice the minor caveats between grade 2 and grade 3. Grade 2, remember, you can miss 3 of, month, day, and week. So for grade 2, grade 2, you can be confused for the month, day, and week. Grade 3 is the one that you don't know the space. You don't know where you are, the location. So because this patient did know their appropriate location, by definition, they are not grade 3. They're still confused, but they're grade 2. This is a challenging question, and I bet a lot of GI and hepatologists would miss it too.
Great, thank you. According to Aishen, how long would you wait to add additional therapy to lactulose for management of overt HE if there's inadequate response to lactulose? 8 hours, 16 hours, 24 hours, or 48 hours?
Okay, great. So majority of you improved. From the pretest, 24 hours is the correct answer. From 36 in the pretest to 63 in the post-test. So yeah, according to the guidelines or Asian guidelines, you want to wait that 24 hours because remember, you can give them lactulose and see if they respond within the first 24 hours. And then if they have no adequate response, then you say within a day, 24 hours, you can do additive therapy. So that's the correct answer.
Which of the following therapies has been shown to improve outcomes and reduce hospitalization when used in combination with lactulose for HE prophylaxis? Lola, PEG, rifaximin, or zinc?
Okay, great. Very huge improvement here. Pretest 70, that's the correct answer. Rifaximin, 73% in the pretest and 96 post-test. I think the ones that chose the other ones, they just wanted to see if they made it onto the list here. I knew they probably knew the answer was rifaximin. But so rifaximin, as the guidelines suggest, as the evidence-based medicine suggests, and the FDA label has been shown that as additive therapy, patients that have failed lactulose and have recurrent overt HE, means get hospitalized while they were on lactulose, that's quote unquote a failure, right? It is into the interest of the patient to be put on rifaximin to decrease hospitalization. And the Bass et al., the Bass New England Journal study in 2010 was the pivotal paper that showed that 50% decrease in readmission by adding rifaximin therapy while on concurrent lactulose therapy showed 50% decrease in hospitalization. That's huge for patients and caregivers. So rifaximin is the correct answer.
Great. Which of the following is among precipitants of HE in patients with cirrhosis that should be reviewed with patients at discharge? Low protein diet, constipation, or joint pain?
Okay, great. That is the correct answer. Constipation, 67% post-tested answered that correctly. So you want to review this with patients, right? Well, I guess I can see why people picked low protein diets because you want them to be on protein. So I can see why that was some people selected that. But you want to review constipation to let the patients know that, look, you're going to be put on a medicine, lactulose, to have 2 to 4 bowel movements a day. And if you do not have, normal bowel movements, I guess you'll be relatively constipated, and that can cause HE. So, it's important to talk to them and as well the patient and the caregiver and say, look, we really need you to have 2 to 4 bowel movements a day. and not be constipated, because if you are, that increases the chance of you getting readmitted for hepatic encephalopathy.
All right, let's try to see if there's any questions here. The first one is 2 grams of acetaminophen still the daily max for patients with liver disease? How much acetaminophen would cause liver disease or liver injury? That is to say, if a patient gets 1,000 milligrams of Tylenol, how long would it take? How long would taking that affect the liver cells? Also, if a patient drinks 3 glasses of wine daily or drinks 2 bottles of beer daily, can they take 2 grams of Tylenol daily without any risk of liver injury? Per CKD, can taking 750 milligrams of Tylenol and 800 milligrams of ibuprofen together cause kidney damage? So lots of stuff around Tylenol.
Yeah, that's a great question. The person probably is a GI and or pharmacist or both. That's a very excellent question and very complex. Yeah, so the answer is 2 grams is safe in the liver for patients with liver disease and cirrhosis. Most people think that it's not safe, but remember, the recommended dose for anyone that does not have liver disease is 4 grams. And you can look on the bottle, it says, let's just assume 500 milligrams for Tylenol, acetaminophen. It usually says take 2 pills every 6 hours, which would add up to 4 grams a day. But for patients with cirrhosis or liver disease, half of that is safe, meaning 2 grams, okay? So that is correct. That does not cause liver damage. Ann Larson, the place I trained at UT Southwestern, she wrote, and Will Lee, my mentors, they actually did the paper on that. And they wrote and they showed that when they looked at all this, 2 grams was totally safe. Now, you threw a little curveball in there by saying if someone, and if I understood the question, it was a long question, but if you add wine in there, first of all, they shouldn't be drinking any alcohol if they're cirrhotic, right? I mean, that's number one, but they do drink, and some are alcoholic cirrhosis. Adding 2 to 3 glasses of wine actually should lower the amount of Tylenol. So instead of the 2 grams, although that's safe, if you find out that your patient is drinking wine, which they really shouldn't because they're cirrhotic, then 2 grams is too high, actually, because you're right. I think what the person was trying to get at, whoever asked that question, was, well, that also affects the metabolism. So I would drop that down to 1 gram if they're taking Tylenol, because they're already causing a filtering problem through the liver. And so that 1 gram is even, you would have to decrease the Tylenol level per day to 1 gram to be safe. Because the liver can, even though you have cirrhosis, it's still working. It's still metabolizing stuff. It just takes twice as long to do so. That's why the 2 grams, 50% reduction. And then with alcohol, probably another 50% reduction to make it, metabolize all the Tylenol, the acetaminophen out of your system. I think there was a question, part of that with chronic kidney disease. Yes, that does affect, that's part of the equation. But it's still safer to take Tylenol than ibuprofen, because ibuprofen, any NSAID, non-steroidal anti-inflammatory drug, not ibuprofen per se, but any NSAID causes not only GI bleeding in our cirrhotic patients, ulcers, it causes acute kidney injury, and they already sometimes have kidney problems. So we would recommend still Tylenol. If they have chronic kidney disease, it's still safe for 2 grams. But usually if a patient's taking, more than 2 grams a day for about a week or so, you got to figure out what's going on there. There could be other alternative medicines that we prescribe that are safe for the liver, not narcotics, but there are some other medicines that we could prescribe. I think I answered most of the question.
Great. If a patient has both liver and advanced CKD, zinc therapy would be contraindicated, right?
What therapy would be contraindicated?
So if they have liver and advanced kidney disease, is zinc therapy contraindicated?
Same therapy?
No. If they have liver and kidney disease, both, is zinc?
Oh, zinc. Sorry, I totally didn't hear you. Zinc therapy. I don't know actually if it's contraindicated. I would say that you would have to ask yourself, what are you giving the zinc for? I would assume that, most people don't even take zinc. Like, I'll be honest, I treat HE all the time. And I rarely even give them zinc therapy. So I actually don't know the answer to that, if it's contraindicated per se, but I can see where you're getting that, or the thought process that with liver disease, it's fine. And I'm not a kidney nephrologist to know that if zinc is contraindicated because of electrolyte imbalances. I would think it would be safe in a short term. But long term, I don't know if it's technically contraindicated. So you're probably not happy with my answer, but I'm not a nephrologist.
And could you comment on DVT prophylaxis in patients with significant liver disease, thrombocytopenia, and elevated INR?
Yeah, so this is all a good question in the sense that we still do DVT prophylaxis. And the reason is this. Most of them have elevated INRs. Their coagulation cascade is altered. I was fortunate enough to write an editorial on this, that patients with, let's say, a high INR of 2, that's a little different than patients being on warfarin or Coumadin to have that same INR of 2. And the reason is this: they have what's called a rebalance homeostasis. All the stuff that we learned with the coagulation cascade and factor 2 and 3 and 7 and all this stuff is very complex. But what happens when you have liver disease, the INR does not translate to how thin your blood is really, because cirrhotics actually are prothrombotic, they form clots, and antithrombotic at the same time. Their INR has no relation to their bleeding risk. Now, granted, when I say that, it's with asterisks. If their INR is 6, that's totally different than a chronic liver disease patient that always comes into the hospital, INR of 1.7, 2.0, 2.5. A Mayo Clinic study looked at INR up to 4 is totally safe to do paracentesis, thoracentesis, other kind of minor surgeries, because they won't bleed, because they have that rebalance homeostasis. They actually clot. So DVT prophylaxis is okay. Now, that's just a general answer. Obviously, if they come in with varicose bleeding, or bleeding for whatever reason, or they have a lower hemoglobin but no overt bleeding, yeah, you can be cautious. You can put on SCDs. You don't have to give them, the heparin that you're thinking for DVT prophylaxis. But there's in the electronic medical system, there would be a checkbox that you say, contraindicated because of either, severe thrombocytopenia or coagulation or bleeding. The thrombocytopenia, also that same Mayo Clinic study, showed that INR up to 4 is safe to do our procedures, right? Paras without blood products, okay? And paracentesis, EGDs. And that same study looked at platelet count, and platelet count above 20,000 was safe. So below 20,000, then you would want to consider giving like a blood product to prevent bleeding risks. Most of our patients are 50,000, 80,000 platelets, INR of 2. So sort of to answer your question in a general term is, yeah, it's safe to give DVT prophylaxis like heparin or Lovenox. Depending on the case, obviously you have to know if they're GI bleeding and if their platelets are, above 50, 30, 40, 50,000, totally safe. But just know that they have a rebalance homeostasis, that they can actually clot and form DVTs. I mean, I have so many patients that have DVTs, and it's hard to explain to them that, well, your INR is 2.5, but you're clotting. So good question. It's very complex.
Great. Let's see. I guess this is on the same thing. Any role for vitamin K? I don't know if that's where, I'm not sure where that is. Okay. Is there new data available for rates of alcoholic cirrhosis through 2022 from GI societies or CDC? Given increase in drinking during the last almost 3 years of the pandemic, wondering if we should expect to see a larger population of encephalopathy and end-stage liver disease.
Yeah, okay. So I'll kind of answer that vitamin K, the question that you briefly asked, and then I'll go into the alcohol one. So the vitamin K, yeah, there's no real role for vitamin K. Now, if a patient comes with a high INR like 6 and they don't have no GI bleeding, it's okay to give vitamin K. They might be deficient in the vitamin K coagulation byproducts because of damage of the liver, meaning the factors that we don't check for, but they might be deficient in that. And usually that kind of is a transition to the alcohol thing. When a patient is alcohol liver disease or alcohol use disorder, or they renamed it, they do lack vitamin K and their coagulation counterparts. You don't have to give vitamin K in general to reverse their INR because you're just fixing a number. You're not really fixing the patient. The patient, remember, can still clot. So there's no real role for vitamin K unless it's a high INR or you're worried about their alcohol and they're lacking that. Because remember, they're drinking their calories and not getting it from the green leafy vegetables that have vitamin K in it, right? So most of those are real severe alcoholics that really have higher INR, decompensated cirrhosis. So yeah, vitamin K, because they're nutritionally imbalanced, you can give it for that case. But in general, for the regular cirrhotics, we don't give that. To answer the alcoholic liver disease, it's actually a great observation. We see that a lot now. And because of COVID, it's caused a lot more drinking. You're exactly right. Usually when I round in the hospital, I would say a third of my patients are alcoholic hepatitis and alcoholic cirrhosis. So let's say I have 30 on service, a good 10 are in there and they're in bad shape. I mean, these are the severe of the severe. They don't qualify for transplant because they continue to drink and so yes, we should expect more hepatic encephalopathy because they have higher portal hypertension. They have more worsening ascites. They come in, they're very jaundiced. These are the yellowest people you'll probably see in general, assuming they don't have obstruction or anything. But their bilirubins can be, 15, 20, really high. And their mortality is extremely high. A lot of discussions on hospice and everything. So yeah, we're seeing a lot more of that. We've seen an increasing amount over the last 3 years. And I think it's going to continue to get worse the way things are going. But that's just an observation. And yeah, more HE will happen. So
I'm just going to end with this one more question. For the super doctor, nephrologists can take NSAID and Tylenol together at dose of 1,000 milligrams, ibuprofen 800 cause. Ortho doctors advised to take them together for severe joint pain or post-arthropathies. I guess the real question here is the combination of Tylenol and ibuprofen, does it cause kidney disease? I don't know, but they're not clarifying whether it's in a patient with liver disease or just a normal patient. Any thoughts on that?
Yeah, I can answer both. In a normal patient without like liver disease, yeah, I mean, if you have a joint thing or you need some anti-inflammatories, which is the NSAIDs, yeah, that's fine in a short term. Everything in short term is fine. The NSAIDs on top of Tylenol, but I'm assuming you're asking, because this is a liver lecture, the patient has liver disease or cirrhosis, most likely. And is that okay to take the 1 gram of Tylenol and then add the 1,000 milligrams or a gram of ibuprofen? I mean, for the ortho, the reason they're doing that because they're honed in on their specialty, right? This goes back to what Dr. Amin was saying about the communication collaboration. They're only looking at it from the ortho standpoint. They did a knee surgery or they did some kind of orthoscopic whatever, and that person has joint or rheumatoid arthritis. They're going to require or want anti-inflammatories, which are NSAIDs. Tylenol is not anti-inflammatory. So yes, I can see it from their perspective. And yes, for the short term is fine. And probably the ortho doctor will say, take it for 3 days or 5 days or a week. And in the interim, short term is okay. We don't like it long term. If you need it for short term, NSAIDs on top of Tylenol, that dose that you mentioned is totally fine. The complication, just know if you communicate with that patient, it should be in the medical chart. It should be documented by the doctor or the healthcare provider. By doing the combination of both, you're at risk for ulcers, GI bleeding, because they're cirrhotic, right? They're an increase. GI bleeding, ulcers, and acute kidney injury. Now, how many of us do that? Probably not that many. But they need to be aware that they need to get their blood work done. It should be short term, maybe maximum a week. But know that these are these complications. We've had some patients that are on, they take it because of headache, right? Or jaw pain or whatever. They just take ibuprofen
for whatever reason, and it's only like 400 milligrams, for like 3-4 days, they come in with a GI bleed. So the higher dose, they're definitely at risk, but I think it depends on the situation. For joint pain or whatever, if they need anti-inflammatory, I probably wouldn't give 1 gram. That would be really high. But I would do lower than that and do it for a short term, and just communicate with the patient that there's risk for those things.
Okay. Well, it was really great, Dr. Rahimi. Great seeing you again. And thank you to our entire audience. Thank you for spending a half a day with us, or 3/4 of a day today on Saturday. And hopefully you get to enjoy the rest of your Saturday. And we really thank, again, Integrity CE for helping get us together, as well as the sponsors. And please remember to fill out your CME and CE. Fill out the evaluation so you can get your CME and CE and MOC credit. So with that, I will say thank you. And Donna, anybody from CE Integrity, any last comments?